Well, the heart has four valves, and one of the most important ones is the mitral valve. And the mitral valve is the inflow valve into the main pumping chamber of the heart. It's made up of two flaps that open and close like this. And in fact, the most common heart valve disease that patients present with is mitral regurgitation, which means a leakage of that valve. Typically, our mitral valves work perfectly, and when the heart squeezes, they prevent any backflow of blood. They're a check valve, and in patients that have mitral regurgitation, the valve leaks. And typically, people that come to us who would need an operation have leakage of about 50% of the blood in their heart goes backwards instead of all of it going forward. Mitral regurgitation is significant because it means that the heart has to work a lot harder than it normally does 24/7. So for example, in order to get a forward blood flow of 5 liters a minute, the heart might have to do the work of pumping 10 liters a minute, and it has to do that 24/7. And while it can do that for a while, with time, it reacts in an adverse way by getting larger and getting weaker. And our goal when we talk about mitral valve surgery or mitral valve intervention is to take away that leakage and to take away that extra workload on the heart and to protect the heart from those adverse effects. Unfortunately, there are no medications that you can take to treat mitral regurgitation. It's a mechanical problem and it requires a mechanical solution. And traditionally that has been an operation, and mitral valve regurgitation is something that almost always can be fixed, where we repair the valve and restore it to its normal function. Occasionally, a patient will require an artificial valve, a mitral valve replacement. As time has gone on, though, we have some exciting new technologies available to us, which, for the right patient in the right circumstance, will allow us to do a less invasive approach. It's always better to get a mitral valve repair, if possible, than a replacement. And there's both short-term and long-term benefits. Mitral valve surgery is extraordinarily safe. However, it's twice as safe if you get a repair as compared to a replacement. And we really don't have a replacement valve that's as good as your own valve. So if you can have a repair, it's better. We have two options for replacement valves, two general options. One is a metal mechanical valve, and the other is a calve valve, or what we would call a tissue valve. And the metal mechanical valve works forever, but it requires that a person take a blood thinner every single day for the rest of his or her life. And of course, that has risks of bleeding that accumulate over time. The calve valve is nice because no blood thinner. However, it wears out after 10 or 12 years slowly, and a person might need another operation or an intervention. In contrast to that, if we can repair your own valve, we can keep your own valve, then that is the best solution, because you don't have to take a blood thinner, and a mitral valve repair is usually a lifetime solution. Not 100%, but we can usually tell patients they have a 90 to 95% lifetime guarantee with that repair. So there's no question that those are advantages. And in addition, when you have a mitral valve replacement, you're always at slightly increased risk of some adverse events, including stroke and infection of that valve. And those risks are higher with a replacement of either type as compared to a repair. I think it's really important, and we've published on this, as have other groups, that in this business, really, in my opinion, more so than any cardiac intervention, it is where experience counts. And it's been shown, for example, that the average heart surgeon in the United States does only about 5 or 10 mitral valve operations a year. And in specialized centers like Hopkins, we have experience doing over 200 mitral valve operations a year. And we've demonstrated in our research that the likelihood of a repair is directly related to the experience of the surgeon. And usually there's typically a threshold of about 60 mitral valve operations a year. So if your surgeon is doing above that, then chances are that he or she is going to have a high likelihood of repairing your valve. And so I think my advice to patients would be to not be shy. And if you get referred to a surgeon, ask them, how many of these do you do a year, and what is your repair rate? I think the other thing that is extraordinarily important is that you have a really strong heart team around valvular heart disease, or what we now call structural heart disease. And it's really a team effort when we're taking care of you and treating your valve disease. And it involves cardiologists, interventional cardiologists, those that specialize in imaging the mitral valve. We work very closely with specialized anesthesiologists, cardiac anesthesiologists, and they're experts at taking care of you in the operating room. And in addition, they also serve a very valuable function with their ability to use ultrasound, echocardiography, to image your valve and to help us do the very best job. So we work as a team, and of course there's all other aspects of postoperative care and intensive care and things like that. So I think you want to go to a place like Hopkins that is a multidisciplinary program that's organized around the care of the patient, and where all we think about is valve disease and how to treat you as quickly and effectively and as least invasively as possible.